Hey everybody, this is your inspirational nurse underscore RN Tierra comes to you live with another great video. This is your inspirational nurse. Hi, inspirational family. I'm sorry it's been a hot minute. Today's video is going to be super special. It's all about the CVT unit. For those that don't know, I will be discussing until kind of what the unit is, how the unit is structured, the expectations, and things that tips and tricks that I learned thus far. I'm currently on a travel contract for 13 weeks. And it's going really great. So I want to share my experience with you guys. As you already know, I'm going to give you the tea on this channel. For those who have subscribed recently, welcome to the inspirational family. Y'all already know. Shout out to all my fellow nurses, the ones that I have came across or worked with, or we crossed paths in the past. Thank you for joining this family. We are going to continue to grow, guys. I'm so excited. I have been going through this week, y'all. I lost my mom 2 weeks ago. So things has been super hard, but we're not even going to go into that. All I would say is cherish your life, and just be very vigilant in this season and watch your surroundings. But today's video is going to be all about your CVT unit. So guys, CVT unit, guys, let's just say that the CVT unit is kind of like a specialized IMC unit, a step-down ICU unit. Instead, it's CVT. It's a unit that is downgraded patients from ICU, and it's not your general med surg floor. So these patients have been on several drips, extubated, intubated situations prior to coming to you. Maybe they had a hypertensive crisis, respiratory failure. They were really sick prior to coming to the step down. You might as well say it's kind of like a step down ICU unit. This CVT unit is structured into 3 wings, the one that I'm currently on. And basically, these patients are need observation still. They still might need an MRI done, CT, once they are stabilized by the ICU and downgraded to the CVT unit. Then the CVT unit monitors their cardiac status very closely. So for those that are really interested in cardiovascular system and the heart and all your cardio drugs and things like that, and just certain drips, then the CVT unit might just be a great fit for you. If you are the type of nurse that don't feel like being bothered with the ICU mess and all the beeping and all the high expectations and responsibilities as an ICU nurse, and then you really don't want to be on a general med surg unit, because y'all already know how general med surg units can be. It's like lots of task oriented, right? If you're that nurse that is compassionate, you have skill sets that you still want to use, that you feel like you want to specialize, but you don't want to go to the highest level of care, you want to be in between, then to me, the CVT unit is perfect for you if you're really interested in cardiovascular system. As you know, anything that affects the heart affects the respiratory system as well. It's all connected, y'all. It's like a big old plumbing system. So you are the plumber. And your job as the CVT nurse is to admit your patient. When you admit your patient, you're going to be, as like when you work at ICU, for those who never worked at a step-down ICU unit, it's set up kind of like the ICU. The only difference is with the units are your drips. Now, the CVT unit does not take cardan drip or like certain like Levophed things, certain drips that's critical, like that's an ICU drip. CVT unit would not take it, but they do drips. So if it's a nitro drip being titrated for a certain diagnosis or reason, if it's a medication that has like full instructions on how to titrate, why we're titrating, then the CVT unit can take that drip. Now, the beauty of this unit is, like I said, guys, for those who are interested in just, you're not sure where you want to work, but you're like me, where you're like, I'm getting older, so I don't want to be doing all the running around. and I just kind of want to just take care of patients and on a decent unit. Because finding a decent unit nowadays, guys, as you know, is hard, regardless of your status in this healthcare field, whether you're a travel nurse, whether you're a PRN nurse, whether you work for the hospital full time. You guys know that finding a dream team, it is extremely hard. And sometimes as a nurse, you will basically find a job that you didn't really sort out in the beginning, but for some reason the team is fabulous and you love the job in the unit. And that's currently how I feel right now. This has been the unit that I have worked on in a long time that I actually enjoyed. Like, y'all usually don't hear me say enjoy a lot, right? Because I have been through hell, guys, with these different jobs and different locations and different hospitals. And this unit, guys, it's set up with 3 wings, and it goes up to 18 rooms per wing. The beauty of working night shift, because guys, I haven't worked night shift in a long time as a traveler. The beauty of working as a night shift traveler, is that you can come in, be creative with your care. If you have a strong personality, or you're in a season of your life where you really don't want to interact as much and you just kind of want to come in and work, the night shift is perfect if you can just stay up, y'all. At 4 o'clock a.m. is when my eyes start to go down, guys. Like, once that sun come up, that girl, is my eyes just be gone. But other than that, I love the night shift because as a traveler, it keeps you out of like a lot of the politics of the hospital and a lot of the gossip and a lot of the drama. As you guys know, that is every single where, and sometimes it gets in the way of you really performing well. Because for me, I just want to perform well. I want to learn. I want to I want to learn new things. I want to learn new drugs, new medications, new skills. And then the only way to do that, I have to be in a setting that works for me. Now, sometimes you think you know what's best for you, and you really don't, guys. Sometimes you be like, no, I'm straightly day shift and da 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 da. But once I've been, like I said, I've been doing travel nursing for over 7 years, guys. And travel, sometimes it's best as a traveler to stay on nights because that's where the team needs you the most, right? They don't have a lot of open slots, or they have 99% travelers, right? So night shift is that shift where there's always going to be a need. So if you can put yourself somewhere where there's always a need and find a great team, that I have been able to work with a lot of these young ladies and gentlemen that have amazing skills, guys. Again, so with the structure of this unit is 3 wings, 18 beds, right? So if it's 3 nurses, do the math. Usually your ratio max is 6. Now, for those who know, I worked in Centera like a couple of years ago, and the ratios were extremely high to like 8. And then COVID time, it went up to 1 to 12, which is very dangerous. I don't even know how I survived 3 years of that. But on the CVT unit, your max is 6. You might start out with 4. Now, these patients are going to be hooked up to the monitor, just like you would do if you was working in a specialty. You'll notice you'll have a monitor in a room. You'll hook them up to their blood pressure, their pulses, so you can see them on their TV. In the nursing station, you can see them in the room, and you can see them in the hallway. So if you're in the hallway and sometimes you're rounding, and you could just take a look up at the TV, making sure nobody's desetting, heart rates are like, whatever. Because on this unit, guys, you're going to see EFs, which means you're basically the heart, the volume, how the heart is pumping out the blood, right? So you're looking at the percentage of that. And sometimes you're going to be working with hearts that's on this unit that's really, really, really critical and really sick. So these are your sick hearts, right? These are the people that come in. And the cardiovascular system could be tricky because your patient can look like they're okay, but on the monitor, they can be in VTAC. Their rhythms can convert over as quickly. Their heart rates can drop or be like way above normal, right? Blood pressure, all of something is being affected, or all of something, their oxygen levels just drop to the 70s. So on night shift is when you see your really, really critical, I'm talking about scary numbers like blood sugars that might be a 16, all your really, really critical numbers you're going to see on night shift. So night shift is a shift where if you have some experience, You're very confident in your skills, then I would say night shift, go ahead, because you don't have the resources that you would have on a day shift. Day shift, you have all your educators, your manager, everyone is at work. But night shift, you kind of have to rely on your team or your charge nurses, which this unit is amazing, guys. These charge nurses work their butt off. Everybody helps out. Everybody, is a team. And if you're not a team player, working with a unit that is a team, it helps you to learn how to be that team player, because you'll have nurses that will help you, which will encourage you to want to be helpful to other nurses. But if you're that nurse and you're like, I just want 2 patients, I don't want my patients talking, then you might be an ICU nurse. You might just want to go that route. But again, part of your nursing journey is to dib and dab into different specialty areas, kind of see what floats your boat or what you kind of like. But on this unit, that is how it's structured. Each unit has a charge nurse, one, and then it has an educator, a manager on this unit as well. Now, this is a fairly new building, so the rooms are really clean. It's really nice, fancy. There's a button for everything. You have to get orientated to the unit, which I was orientated to the unit, and it still took me a while. Because it's 3 wings. So sometimes I will get turned around and lost, but that's normal. That's normal as a traveler. You're going to get turned around and you're going to be like, wait, which way am I going again? Which wing? And I'm finally feel like now, and I have like a couple of weeks left to my contract, that I finally felt like I got it. But on this unit, you will see maybe 3 to 4 drips that they only do and only accept. They do not accept any extreme, critical drips. There's one time where I had to float to the ED, which was a crazy thing because, the supervisor was telling me, hey, you might get ER patients or you might get inpatient patients, because they have CVT patients that's in the ER. Then they have the inpatient holding area for where you go down there. And you're kind of just doing the same thing you would do on the unit, but just down in the ER, which I had the pleasure to be down there. I was able to I had to do an ICU drip. The nurse really didn't know anything about the patient, so it didn't fit well with me. Again, you will learn yourself as a nurse when you are put in certain situations, because sometimes we desire, I'm gonna go to the ER, that's my thing. I love trauma. But when you get to the trauma or you get put in that situation, your anxiety, your behaviors, your responses will tell you if that is the best fit for you. Obviously, for me, I learned really quickly that I am a critical care nurse, IMC, ICU type of deal. Those are kind of my thing. I do like a little bit more laid back unit where I could just come in and perform my job, because I'm just such a busy person in my life, my personal life, that I need a unit that I could just come in. It's not so stressful. And, the normal stress of nursing, but not to the extreme, where I'm like, I don't even want to come to work, because you have to come to work to pay your bills. Now, if you haven't worked a CVT unit, of course, you will be orientated. On this unit, I had a week, I want to say, or 3 to 4 days of orientation, which was really impressive. This was the very first time in a long time that I had a very deep and thorough orientation as a traveler. So that's always going to be a thumbs up for any facility or hospital that give you more than a day. As a traveler, it tells you that that's a facility that is well managed. They have a system going on. They probably had some incidents that occurred, on their units that they don't want happening again. So they are putting these things in place so that travelers can come in and feel safe to practice. Because again, whether you are a traveler or not, the hospital motive should be, we want our nurses to come in and feel safe when they come, whether they're visiting for a short time, whether they're coming to stay and want to, stay with the team. You want all your nurses to feel safe to practice, because that's what's going to bring your travelers to that location, right? And fill those slots up. Because regardless of how fancy a unit can look, if you have no nurses to work it, you are screwed, right? Because nursing is a 24-hour gig. Now, I had the pleasure of having meet with the educator and kind of go through the unit, even though, I was night shift. which was great because you always want to be orientated to the unit because you always want to learn how their policies are, how to locate that if you have questions or you get a medication that you're not quite sure, or you are, you have to do a particular observation with the patient or assessments. You want to be able to reference to their policies. Now, guys, when I started in orientation, I made a really good impression because when I was during orientation, they wanted to see our skills as far as certain things like putting in a Foley and, working the pump for pain, like they had the pain pump. Certain procedures they wanted to see if we were able to just do it on the spot in practice. And I was able to say, hey, when you put this in, they don't deflate the balloon here because their policies is this. And, all the travelers was like, what? How did you know? So again, as a traveler, you want to travel safe. The first thing you want to reference to is your policy. That is your Bible. Because regardless of who, what, where, or what happens, when something happens or ever been in a situation where you had to do something for a patient and you wasn't quite sure what the expectations were and everybody's just so busy, or you're like, oh man, who do I talk to about this? And they like, man, and you might get some responses from nurses that be like, maybe you got to do this, or, maybe I do this though. Doesn't make it right, right? So you want to always be able to know how to reference your policy. So the unit was structured really, really well. The team was really, really nice. Everyone kind of talked to you. Everyone greets you. All the employees were really sweet. A lot of travelers. So you definitely meet travelers from all over. With shout out to all my fellow travelers that I had the pleasure to meet and work with. These patients, like I said, they're going to come in and they're going to be coming from like the medical ICU or the cardiac ICU, which is the CCU, or the MICU. So most of your transfers are coming from a critical care unit, ICU unit. You will get report. You want to find out important things when you're taking report from a ICU nurse, or you're giving them a patient that maybe went critical on you that can no longer stay on the CVT unit, that need to be upgraded to ICU. So key things is you want to make sure, like if they were on a drip, did they have any recent vital signs taken? How long ago was that drip stopped? And making sure that the patient is stabled. Because as you know, when something is stopped after the patient's been getting it for a while, there can be side effects to that. So you want to kind of ask a lot of questions as far as, okay, if they was on a drip, the titration information, how did they tolerate it when they was receiving it, and for how long they had to receive that drip. If you get an ICU patient that was intubated or extubated, meaning they had a tube down their throat to help them breathe, you kind of want to ask, okay, well, when was they extubated? Meaning, when was that taken out? Because it takes the body time to adjust to not having the tube down the throat. Because when they do all that, they sedate the patient. So everything with your patient is going to be slow. They're not really going to be peeing for a while. Their bodies is kind of going to be trying to get back into the natural rhythm of things. Everything slows down. They may have some damage from putting in that tube. So you want to make sure that you ask, because sometimes the problem is between the step down, like ICU and ICU, is that sometimes they rush the patients off the ICU too quickly into a step down ICU just to downgrade them. But they just got off all these heavy drugs, all these heavy drips, and it didn't give the patient time to kind of come back to it. So you might get a patient that's still like out of it, vitals are still wonky, they just been extubated. You need to make sure that they are clearly breathing. Their assessments are on point when you're taking ICU patients. Now, I had the pleasure of taking patients to the ICU, in which I forgot what that scenario was, but by the time I got to the ICU with my patient, everything was kind of done. Like, if that makes sense. Like, I already, like when my patient was coding or not doing so well, you always want to grab a blood sugar, which my charge nurse was like, oh, wow, I wouldn't even think to do that. I was like, yeah, like you always want to make sure you grab blood sugars. I have tons and tons of patients that has an insulin pump on this unit as well. Those insulin pumps are very, very dangerous. Patients can be very sensitive to the boluses that they're giving themselves because they're not quite sure how to use it as of yet, like where they mastered the use of this device. So make sure if you're getting an insulin pump, you have orders. There's times where patients might come on your unit with one that's if the pump is on and they're doing whatever in the room and you don't know. I had a patient that blood sugar dropped to the 16s because she was sneaking in after we locked it up. It was bolusing herself. Because it was her security blanket. She felt like this is like what she had to do, even though we was, giving her a sliding scale. Most of the time, you're going to get patients that's diabetics. You're going to get surgical patients that's getting the cabbage or had open heart surgery. Yes, you can get patients on that hearts are very, very sick. And they're going to go and get surgery. So most of the time when you get a patient on the step down ICU, make sure that you go through the orders really quickly. And the first thing you want to check for is to make sure if they're going to be NPO after midnight. Are they going to still be running tests? If they already ran tests, you need to be looking at those results while you're getting a report from the nurse. You want to, and another tip is you want to look at the H&P notes from the provider because that will give you a summary or a glance and like it kind of puts all the information together in a story. So you kind of know what happened to your patient, how they wound up to the ICU, what they was doing prior to that led to the situation, their status, what the providers, all the doctors that's on the case is working on, what their focuses are, because you might see something about potassium and you might get the hint that, okay, maybe when this patient comes, I'm going to be running some bags of potassium or magnesium or whatever. So you want to look at the H&P notes because sometimes when you're getting report from other nurses, it's a little vague report, but that's okay. They don't have to give you like a full 2-hour report. They need to make sure they're giving you the important information. So bedside report is very important because these patients have PICC lines, they're dialysis patients, they just had surgery, so they have all these incisions and all these different things that you want to make sure that you are checking. So you always want to make sure you're checking your lines. So if the patient was running a certain drip in the ICU, you want to make sure you check your IVs site to make sure your site is still flushing, is still there, still working. It's not going to turn the skin black or anything. Like, as you know, if you give Levofed drip, which is an ICU drip, which you have the pleasure of titrating doing, you want to also assess the line with that drip because that it goes in the skin and the surrounding tissues and it tears it up. Just like potassium, sometimes we run up so many bags of potassium that it tears your line up. So you want to, main thing is you want to flush your lines. You want to make sure that your lines is working. I always tell my patients that, these lines are your life-saving tools because without this, if God forbid your heart was to stop beating or your rhythms convert and we need to, code you or anything, then I need you to make sure that this IV site is working. And make sure you cap your lines. I can't stand IVs that have no lines. They just open to air, and these patients can get infections through their lines. I don't like it. But yeah, so your unit is structured that way. You had a week of orientation, which is good. We discussed that. Your ratio goes up to 6. Now, every CVT unit might be different per hospital. Some hospitals might have a higher ratio. Some hospitals may have a lower ratio because these patients can be very, very, very sick. They can be in a negative contact room. They can be, have a lot of respiratory issues on top of their weak heart. And anything cardio is kind of like a silent killer because sometimes if you don't check and round on your patients, they can already be coded in the bed or dead in the bed. That's how cardiac is. They can appear one way. The patient can look comfortable. I remember we seen a guy that was like literally VTAC and he was just laying there like he was on the beach. You don't know what you're going to see. Definitely night shift is when people are the most sickest. They start to cough more. They start to can't breathe more. You take care of patients, maybe their EFs are 5%. I think the lowest I took care of was like 5% or 3%, meaning that's their battery life for their heart. I always tell the patient, your EF is like your battery life to your heart. That is what battery is left, the level of battery is left in your heart. And they go, oh, is that all that is? So that's the way I explain things to them. On the CVT unit, be able to educate your patients and families. They are very nervous on this unit because they just came from the ICU, the patient, and they have lots of questions about their care and their status. And, maybe they're still feeling the effects of the drugs that they were currently on in ICU. They might be in a lot of pain because they just had a surgery, they just had heart surgery done. So those patients, you do want to watch. Definitely want to watch your cardiac patients. Again, cardiovascular system is very tricky. Even though the heart has its own electricity, I'm like electricity, it does its own thing. And at any time, the heart can stop. So when we have a patient that is like going down to a cabbage to get a cabbage done in the morning, or their hearts are really sick, like it's doing wonky things, we automatically put the pads, the pads that we will put on you when we're cardio versing you, like when we're changing your rhythm to shock you or anything like that. We will go ahead and put those pads on then, because God forbid overnight that your patient codes, you already have the first step done. On this unit, we also have the resources of a rapid response nurse. That is about 2 of them that come by the bedside to help you. Now, these are supposed to be your ICU nurses because they have the iStat. They can go ahead and get different labs ordered and different things ordered, or direct the charge nurse on how to care for the patient or what to do in the situation. We also have lab support on this unit where they draw all the labs for you, unless your lab is if your patient has a line, then you can draw from the line. They won't touch the line. But everything else they draw, which is nice to have that resource. Also, what other resources we have? Transportation during the day, but I'm night shift. We don't have that on nights, but nobody really goes anywhere at night. That's kind of rare. So you might have time-sensitive medications that you have to give. You're definitely going to be given a lot of blood pressure meds because, again, your blood pressures are going to be all over the place. Now, in this facility, they do have a sepsis actual protocol that they have, which I think is really neat. On my last job that I was managing, I was trying to get the company on board with having a sepsis protocol, or like certain protocols, because if the nurses have protocols, then they can just act instead of like trying to page the doctor 2 o'clock in the morning for something if they know their patient is going to be septic. Now, the cool thing about it is it grades your patient based off the documentation that you put in. That's why documentation is very important, guys. Also, it's very important as a nighttime nurse to document, because that way, if your assignment is heavy, you might want to look at the grade. It grades all your patients and their acuity, and that will tell you if your assignment is inappropriate, and then you can have a conversation with the charge nurse as well. But if you don't document, it won't like pick up on those key things. Like if your patient have a G-tube and they have feeding going and they have central line going and they have all these medications going and they are total care and all these different things that you have to do for the patient. If it's not in there, it's not going to calculate it. It's going to look like the assignment is easy when the assignment actually is not. So that is one way for you to keep up with, as far as knowing, okay, if this is an appropriate assignment. Because when you have patients that have cardiovascular issues, there's always going to be something going on with their respiratory system, or there's something, like I said, they need breathing treatment, or something, their rhythm just converted over to AFib, and then they're at risk for having a stroke. Now, they're going to be receiving blood thinners, so they might bleed. I had a patient that was bleeding a lot from a blood thinner. So you want to make sure that you are documenting on your patients, so that way the charge nurses can make the assignments appropriate. Now, these charge nurses, I give them credits. They some of the amazing charge nurses that I've worked with in a long time, and they try to be fair as far as that. But I don't think everybody can, learning these skills takes time, especially when you're in leadership. It takes time because sometimes things take priority over you learning your job. So when you come in as a leader or a charge nurse, you're like, I'm already dealing with trying to make the assignment for tomorrow, and somebody called out. And so those take up time for you to learn different things for your job, right? To be a better charge nurse, to be a better leader. I know as a manager, things always took priority over me, like really practicing certain skills. Whether I'm answering all these emails, my phone is ringing off the chain, the staff is getting into it, families had complaints. It was just so much that just takes up a lot of the nurses' time. And I think these facilities have high expectations on nurses when they don't realize what comes with the workload. And as nurses, our duties is to speak up and always advocate for yourself, no matter where you work. Always speak up for what's right. Even if it doesn't, you're like the only one that's like speaking up, because sometimes it feels awkward when you do the right thing and you expect other people to be like in your corner and you like, we know that's not the right thing, I wouldn't do that. It feels awkward because you feel like you're all alone, right? On the lone land by yourself. Always do what's right, y'all. Y'all already know I'm going to tell y'all, do not be out here traveling unsafe. These are real people with real problems. My mom had a lot of cardiac issues herself. She was getting a lot of blood transfusion because she was very anemic. She had a lot of things going on, and she died at the age of 58. So take care of yourself, especially when you're having blood pressure issues or you're feeling dizzy or something, or you're sweating more. Make sure that if the patient's going for a stress test, they understand what entails in that stress test. Make sure the NPO, make sure you're explaining the importance of all of this so it doesn't interfere with any test results, because you don't want your test results to be inadequate, right? And the doctors are basing their medications and treatments off of your results. So you want to make sure that your stuff is accurate, your documentation is accurate, and you educate your families. Again, the unit is set up almost similar to the ICU. Like I said, the only difference is your different drips. The ICU might have 4, 5, 6 drips running. Sometimes we have 2 to 3 running. I've seen the most on this unit so far, which everybody's so helpful to help you get set up. You're going to be running a lot of mag, potassiums, blood, things of that nature, because these patients' lab levels are always being drawn. So doctors are staying on top of making sure that they're ordering these things so that the patient, doesn't have an adverse effect to anything, right? You also want to make sure you're checking allergies on this unit, because there's times when you are, you moving really fast and there's a lot of medications that you need to give them. And if you're not careful, because some people have like 2 pages of allergies. I'd be like, who got like 2, 3 pages? Like they have a whole book of allergies. So you want to make sure you're checking your allergies. Always making sure you identifying if it's the right patient. Like always check the armband, because there's times when they still have an old armband on and not a new armband. And you want to make sure that you have the right patient, right? Because things happen, right? Because there's such a short staff. Sometimes things happen. The wrong patient might go to the wrong room, or there's a miscommunication. So you want to do that. On night shift, guys, I make it fun. Like I spoil my patients. If they can have it, I'll spoil them. We do a lot of education. I try to make education really cool and make it where they can understand where you're coming from, because these patients are really, really sick. They have a lot of vascular issues, where to the point where you wish you was a provider and you can do surgery and help them, right? So they can have some relief. And it's really hard seeing patients really, really sick. But sometimes like I said, cardiovascular system can be very tricky. You can you be like, oh, my patient is good. And next thing you know, you go back and the patient is gone, or the patient is coded, or something has happened in such a short time. On this unit also, we don't, in the beginning of the shift, we don't print out our strips. Like how I was about to say how I was raised at another hospital. We always, in the beginning of the shift, we look at our rhythms as soon as we come in. We print our strips, we measure them, and then we put them away so the providers can see it. And then we do it again throughout the shift. This unit, the charge nurses kind of is on top of that, printing the strips, looking at the monitors and everything. And you don't sign off until the end of the shift, when all your rhythms for the shift has been printed out by Tele and sent over to the unit, and then you just sign to verify that the rhythms were correct. So take that time to learn your rhythms. This is a unit that you definitely have to learn your different types of rhythms, your bundle blocks, your first degrees, your Mozarts. You got to know all your rhythms on this unit, because I've seen patients convert so many times from normal sinus to all of a sudden a SVT, all of a sudden a VTAC. Your rhythms are really, really, really something you have to know. And if you don't, really not strong in that area because your school really didn't teach you really well, there's a website called Skillset, I believe, where you can go on for free and practice your rhythms. And it basically just runs a strip across and lets you pick to see which one it is. And then you can keep practicing until you get it right. You might see a lot of PVCs. You might see a lot of artifacts. As far as I didn't see a lot of junction rhythms so far, which is really a rare rhythm, but I did see some really, really cool rhythms on this unit. So again, cardio system is tricky. The patient look fine, but their heart is a hot mess. And you can't see visibly their hearts, right? It's inside their chest. So your job is to monitor the monitors. They'll always wait for the charge nurses to say, hey, you need to go check on that patient. You should be already checking on that patient to see if anything is interfering with that rhythm. Is that a true VTAC? Is that a true VFib? Like, you want to make sure it's a true rhythm, and you don't just go with what you see, the first thing that you see. You need to make sure that you let the rhythm runs for a while to look at the time, like maybe more than 6 seconds, just to make sure that is a true VTAC, VFib. You can go back in the monitor. You can go back to see what their rhythms were in that morning, during the morning shift. You can kind of see how their rhythms were during the day, and then compare it to night shift to see what might have changed or what needs to be done. And then communicating with the doctor is key on this unit, guys, because their statuses change all the time. 1 minute your patient could be stable, 1 minute they won't. So you need to make sure that you're verbalizing with your providers on what is going on, and make sure that you are providing patient-centered care. These cardiovascular patients are tricky, but the key is with them is to listen to what the patient is saying. If they like, yeah, I was working today and I realized I was a little twinge here, they might not say it's chest pain. They call it a twinge, or they call it something else. You need to be listening when your patient is talking to you about their routines and their stresses at home and the things that they're dealing with. And then they're like, yeah, all of a sudden I just start sweating. I didn't know why. I just, then this happened and that can help the provider to provide the right treatment for the patient. So communicating and paging the doctors right away is going to be key to get a quick response. And you really do get a quick response. Every computer has a phone next to it, so the nurses have like their own little phone. It's like a home phone, but the doctors can call you on it, and you guys can have that conversation. You're going to see a lot of anxiety from these patients as far as their psychosis, as far as their mental health go, because again, these patients are experiencing things and they don't kind of understand the full concept. It brings the anxiety high, or they're scared to go back home, or they're scared to go back to work because they don't know what's going to happen, or maybe they don't have the support. Maybe they still need more rehab, or they need placement. It's just a lot for them. So anxiety, you want to make sure you're treating that, because that also can interfere with your results with certain things when you're doing your assessment. Because the patient is having a full panic attack and you're like, oh, they're having a heart attack, and it's really mental. But if you're not paying attention to your patient, these are the things you won't know. Don't always expect something like the first thing you see. Always question things. Always look at your surroundings. Listen to when the families are talking, the visitors are in the room and they're having that dialogue and they're talking. You need to be listening to see any hint, any keywords, anything that can help, especially when they cold. And because the patient, they might ask you, hey, so what happened in the last 30 minutes with this patient? What was they doing? Like I had a patient that was just talking on the phone with their husband, and all of a sudden, like their machine was just like, whoop, 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 whoop. Like their heart could not even take a conversation on the phone. That's how sensitive their heart was. Any little stressor, it just turns them into something. It just turns the rhythm into something else. Right. And that's just talking on the phone. So you want to be paying attention to the activities of your patient. You want to be vigilant into their surroundings, into what they're telling you and what happened. Listen to what they tell you, because it can save their life. It's not always the signs that because we all know the signs, but some things you can't explain, right? But if you're paying attention to what the patient is telling you, like, hey, yeah, I noticed I ate this, and I did this for the first time, or this and that can be a clue to what happened to them when you do have things or they cold and you do have things that go down. It make better sense to you. So this is your inspirational nurse. I hope this was super helpful. Again, I had finally found a decent unit that I enjoyed performing, working my skills and learning things. On this unit also, you're probably going to learn a lot about life vests and defibrillators and pacemakers. You might get a lot of patients that need pacemakers on this unit that they're bradying really, really, really low. So a lot of devices you will be learning also. So if this is your thing, girl, or your thing, y'all go for it. Get the skills. So far, I have been here for, I want to say 5 weeks, 6 weeks. And it's been going really well. It's not so overwhelming where it's impossible to like really give my 110%. It's actually decent where I can come in and work. And it's set up to succeed. They set you up to succeed on this unit. So shout out to this unit. I would definitely give it a 9 out of 10 for my own personal ratings. I would definitely recommend. And sometimes you was tell this is something you don't do as a traveler. Don't be like, I would never go to that hospital down the street. Or I would never do this. Or I would never go there because of that. Don't ever say never, because you never know where you might wind up at in your nursing career. You never know who you might be working with or working for in your nursing career. So don't ever limit yourself and say I would never, because things do change, right? Units are being created. This was one of the units that was created because of the overload of the ER patients downstairs with cardiovascular issues. So they created this unit. So units are being created, right? Things are changing. So don't always limit yourself and say you would never do something, because then you're just limiting your growth, and you never know, because God might just put you there and you be like, oh Lord, I love it, so you just never know. So watch what you say out your mouth, because, like I said, you just never know how tables will turn and where you will wind up in your nursing career. But if you find a team that is awesome, that treats their travelers with respect, then I would suggest be the unit for you. This is the Inspirational Nurse. Talk to you soon.